welcome everyone. My name is Simran Chaudhary, and it is my pleasure to welcome you all to today's special awareness session Navigating Migraine with Experts, Not Assumptions, Moving from Myths to Medical Expertise. An initiative by Voice of Healthcare and powered by Amneal Healthcare. Migraine is often dismissed as just a headache, but for millions of people, it is a chronic neurological condition that disrupts education, career, family life, mental well being, and overall quality of life. Despite affecting nearly 1 in every 6 to 7 individual, migraine continues to be misunderstood, underdiagnosed, and frequently undertreated. So many patients continue to self medicate, normalize their symptoms, or delay seeking specialist care, often because of some myths and misinformation which is available. So, at Voice of Healthcare, our mission has always been to bridge this gap between medical expertise and public understanding. So today's session has been designed with exactly that purpose to bring together some of India's most respected neurologists to answer important questions, dispel some misconception, discuss the latest scientific advances, and empower patients with reliable evidence-based information. And this initiative is powered by Amneal Healthcare, and we sincerely thank them for supporting this important public awareness campaign. Now, it is my privilege to introduce our distinguished panel of experts for this session. Dr. Arvind Sharma, Secretary of Indian Stroke Association, Head of the Department of Neurology at Zydus Hospital, Ahmedabad, a member of Board of Directors of the World Stroke Organization, and President of Society of Neurosonology. Welcome to our show, sir. Thank you so much for joining. Thank you, sir.
Namaskar.
Dr. Achal Kumar Srivastava, Professor in the Department of Neurology at AIIMS, New Delhi, President-elect of the Movement Disorder Society of India, Secretary of Delhi Neurological Association, and Secretary of the Nerve Muscle Society. Thank you so much for joining, sir.
Thank you so much.
Thank you, sir. I would like to welcome Dr. Ashish Kumar Duggal, Professor in the Department of Neurology at ABVIMS and at Dr. Ram Manohar Lohia Hospital, New Delhi. Thank you so much for joining, sir.
Namaskar.
Thank you, sir. Dr. Vineet Banga, Director and Head Neurology at Fortis Hospital, Faridabad. Thank you so much for joining, sir, and welcome to our show.
Thank you.
Thank you, sir. Dr. Anshul Rotangi will be joining us shortly. And to begin our conversation now, without any delay, I would like to ask my first question to Arvind, sir. So, as we all are here for this public health awareness campaign, to set the context for today's discussion, let us begin with understanding of this magnitude, this problem. So despite being one of the leading causes of disability globally, migraine is still widely misunderstood. So, how serious is the true clinical and societal burden of migraine today if we have to understand this?
Thank you, Simran. Thank you very much. And Namaskar, Sabiko, and with my respected co-panelists. And thank you to AMNL. And it is a wonderful initiative by VOH for creating awareness about the most common symptom, neurological symptom to anybody. If it is even more common than what is diabetes and asthma is. And those who suffer, they know about it. जिनको होता है उन्हीं को पता लगता है कि ये सरदर्द क्या है. अदरवाइज टेंशन हेडेक या मुझे स्ट्रेस के कारण हेडेक है या मुझे स्पाउस के कारण हेडेक है, उसे स्पाउस हेडेक नाम दे दिया. बहुत सारी मिथ्स हैं हेडेक्स के लिए. पर टू अंडरस्टैंड हेडेक, अंडरस्टैंड माइग्रेन is very important. It is a very complex disease and it's a lifestyle disease. और उसका मैग्नीट्यूड अगर WHO के कंडीशंस में अगर हम देखें तो it is equivalent. A severe migraine attack is compared equivalent to quadriplegia, dementia even, right? If you see the guidelines and if you see how bad a 1 day of migraine is equivalent to. So the magnitude is very high. The only problem is people don't want to identify it, don't want to get it treated. And the numbers are very dismal for the treatment. And even they take the treatment, they don't take long enough because they always ask for the cure. And you always say that it is the only disease During my residency, also, my teacher used to say, my teacher, Dr. Professor Vivek Lal, he used to say that it is the only disease which if you treat it well, it decrease with the age. There is a bimodal agreed, but definitely it has to be treated, which is very important. Namaskar.
थैंक यू सर, थैंक यू सो मच फॉर आंसरिंग दैट क्वेश्चन एंड आई बिलीव कि इसकी डेप्थ, इसकी डेंसिटी कितनी है उन लोगों को शायद नहीं पता जिन्हें ये नहीं होता है. सो आई थिंक थैंक यू सो मच फॉर स्ट्रेसिंग अपॉन दैट. Moving ahead to my next question, so Dr. Ashish, that certainly highlights how misinformation can delay appropriate care. So if you could help us understand that migraine prevalence in India is estimated between 14 to 20%. So why do so many patients still remain underdiagnosed or undertreated?
So, as Dr. Arvind sir just said, see, migraine is very common. As you said, 20%, almost 1 in 4 will have migraine. Probably one or two amongst us will be having migraine. The problem with migraine is there is a lack of knowledge about migraine at all levels. Patients don't understand. उनके लिए जैसे सर ने बोला ना, मामूली सर दर्द है, कभी साइनस पाउस, उनको सर दर्द होता है, द फर्स्ट थिंग दे गो टू अ नियर बाय फार्मेसी, टेक अ पिल, उससे दर्द ठीक हो ना हो, एंड दैट अल्टीमेटली लीड्स टू क्रॉनिफिकेशन. तो अगर हेडेक सही से नहीं ठीक होता तो क्रॉनिफिकेशन हो जाता है. तो पहली चीज है कि पेशेंट्स को नहीं पता कि उनको माइग्रेन है, कि माइग्रेन जैसी कोई चीज है, उसके लिए सर दर्द के लिए अगर ज्यादा जल्दी जल्दी हो रहा है, देन दे शुड गो टू अ डॉक्टर टू शो देम. Then another problem is even at the physician level, the MBBS, MD undergraduate level, headache is not considered a priority topic for teaching. Even at DM level, I would say okay, we don't give headache cases in the final exam. So misdiagnosis is occurring at the level of the doctors also. So they don't properly diagnose migraine, then they are under treated. Again, prophylactic medication जो मिलनी चाहिए patients को जिनको frequent headaches हैं, उनको prophylactic medicine नहीं मिलती. और तीसरी चीज है कि कॉस्ट एक इंपॉर्टेंट फैक्टर है, इंश्योरेंस एक इंपॉर्टेंट फैक्टर है. माइग्रेन वाले पेशेंट मोस्टली ओपीडी में जाएंगे, इंश्योरेंस इज नॉट कवर्ड. इवन गवर्नमेंट has started Ayushman Bharat, but Ayushman Bharat में the only thing that is covered is the hospital admissions. And migraine patients are not admitted. The medicines they need to take regularly. Some of the medications may be expensive. They need to go to far off places, especially in rural areas. So all these things, and then there is another thing, stigma hai. Most of the migraineurs are females, and when they are working at home, and sometimes it is believed by the family that yeah, headache, she's saying headache because she doesn't want to do the chores of the family. So this creates a stigma, and most females, in spite of suffering severely from headache, they continue to work so that the headache then becomes more chronified. And finally, we did a study for migraine in urban and rural areas, and we asked the patients what amount will they be willing to pay if this headache goes away. And you won't believe they are not willing to pay anything because they think that this headache is just like another headache and we will go through it. So these are the gaps which ultimately lead to decreased healthcare utilization and ultimately causes chronification, therefore increasing the burden of migraine in the society.
Thank you so much for explaining us that even with this much of prevalence, how and why people are still ignoring this and just treating as a normal headache, and which leads to a bigger problem out there. My next question is Dr. Achal. So, like Dr. Ashish explained us about the prevalence and the current scenario of migraine in our country, even with that, there are a lot of myths around migraine that contribute to impact of timely diagnosis and evidence-based treatment. So if you could explain us on and shed some light on this aspect, sir. Dr. Achal, can you hear me? So
Sir,
can you
Yeah,
hear?
yeah, I can.
आवाज.
Is my voice
Yes, sir.
audible?
आ रही है
Yes,
सर.
sir.
Yeah. So, so there are actually several myths, as you people said, that's commonest problem, and similar is the experience with us as well. It's a commonest problem to come to the OPD. However, there are several myths attached to this particular disease. So one of them is that people think that it is some mild disease, need not worry at all about this, and just have some medication, it will improve. It's not required to go to a hospital or to a doctor, not needed to consult a doctor. Other myth is that people think if he's a male, he thinks that it's a disease of female. I will not be affected, so I need not worry at all. And there are other things like people think that there is aura affected with this disease. If there is no aura, it is not migraine. Whereas the commoner migraine is without aura. So these are some of the myths. And people think that unless there is some finding in CT scan and MRI, only then it is migraine. So it is a myth again. There is no finding in CT and MR if you are looking into a CT and MR of a patient of migraine. And moreover, people think that what is the use of taking medicine? Just I will ride over the headache, maybe for some time, and it will improve by itself. So there is no need to consult a doctor. However, nobody is bothered about the long term implication which this particular headache is having on those people. So several myths needs to be tackled, and probably I'm sure this kind of a program will help them. Thank you so much.
Thank you, sir. Thank you so much for shedding light on the myths and misinformation which is there. Uh, Moving on to my next question to Dr. Vineet. So, early identification often changes the outcome very significantly, and especially in chronic neurological disorders. So, from an early recognition standpoint, what symptoms or patients should clinician, should be vigilant about from primary care providers aspect?
माइग्रेन इज सच डिजीज जिसमें आप जितना जल्दी पता करते हैं कि माइग्रेन है आपको, उतना उसको जल्दी से अच्छे से ट्रीट करते हैं, द मोर आर द चांसेस कि वो क्रॉनिसिटी में कन्वर्ट नहीं होगा. फॉर एग्जांपल, अगर आपको महीने में 1 या 2 बार दर्द हो रहा है और अगर आप उसका प्रॉपर ट्रीटमेंट करते हैं ट्रिगर पता करके मेडिसिन लेके, तो द चांसेस कि वो 3-4 बार या 20 बार होगा महीने में, उसके चांसेस बहुत कम हो जाते हैं. और उसके लिए सबसे ज़रूरी ये जानना है कि माइग्रेन कोई एक नॉर्मल दर्द नहीं है. नॉर्मल दर्द मतलब आपको खांसी जुकाम है तो दर्द हो गया, आपको बुखार है तो दर्द हो गया. बट अगर उसके कुछ पर्टिकुलर कैरेक्टरिस्टिक्स हैं, जैसे कि बहुत तेज हो रहा है, उससे आपकी रूटीन डिस्टर्ब हो रही है, वॉमिटिंग आ रही है. एक बहुत कॉमन जो मिसकॉन्सेप्शन हम लोग देखते हैं वो ये कहते हैं, डॉक्टर साहब दर्द नहीं होता, मुझे एसिडिटी होती है. सो दैट्स अ वेरी कॉमन मिसकॉन्सेप्शन कि लोगों को लगता है कि एसिडिटी की वजह से सिर दर्द हो रहा है, ना कि सिर दर्द की वजह से एसिडिटी हो रही है. सो जो कॉमन चीजें हैं वो ये हैं कि अगर आपको हेडेक के साथ वॉमिटिंग हो रही है, आपसे लाइट बर्दाश्त नहीं हो रही है, आपका मन करता है अंधेरे कमरे में लेट जाएं, आपकी रूटीन डिस्टर्ब हो रही है और वो आपको बार बार हो रही है और परेशान कर रही है, तो वो अर्ली वार्निंग साइंस हैं जो कि आप हमें रिकॉग्नाइज करने चाहिए. एंड द सूनर वी रिकॉग्नाइज इज द बेटर वी विल बी एबल टू ट्रीट इट and prevent it to at a stage where it becomes chronic and not amenable to treatment or difficult to manage.
So as you mentioned कि लोगों को misinformation होता है कि that this could be due to acidity or something and then they take it medicine. So following up on that, many individuals rely heavily on over-the-counter medication which is quite easily available from the pharmacies and etc. So that results into delayed consultation. So what systemic and behavioral factors are contributing to late presentation in migraine care, sir?
तो सबसे इम्पोर्टेंट तो ये है कि ये सोचा जाता है कि ये हेडेक ही तो है, हेडेक से क्या ही हो जाएगा, एक नॉर्मल हेडेक है. और इंडिया में इतनी ज़्यादा OTCs अवेलेबल हैं, किसी भी मेडिकल स्टोर पे जाएं और हर मेडिकल स्टोर पे या हर दूसरा इंसान जो आपके पड़ोस में रहता है वो डॉक्टर है, तो उसको सारी दवाइयों का ज्ञान है, वो आराम से पेन किलर खाते रहते हैं. और ये एक बहुत कॉमन रीजन है, ये जो ओवर द काउंटर मेडिसिन हैं जो नॉन प्रिस्क्राइब्ड फॉर्म में पेशेंट्स लेते हैं बहुत लंबे टाइम तक, धीरे धीरे वो मेडिकेशन ओवर यूज हेडेक में कन्वर्ट हो जाता है. तो मेन प्रॉब्लम है अवेयरनेस, कि ये सोचना कि ये सिर्फ सिर दर्द है. और जैसा कि आशीष सर ने बताया कि पेशेंट से पूछा गया कि आप कितना पैसा खर्च करना चाहोगे अपने माइग्रेन को ठीक करने में, तो वो खर्च करने को तैयार नहीं थे. तो एक बहुत बड़ा रीजन है कि वो मेडिकल स्टोर के वाले के पास तो चले जाएंगे OTC लेने, लेकिन वो डॉक्टर के पास नहीं आएंगे क्योंकि वहां कंसल्टेशन पे करना पड़ेगा. जबकि ओवर टाइम अगर आप देखो तो जो टोटल कॉस्ट एक्सपेंडिचर जो क्वालिटी ऑफ लाइफ खराब होने की वजह से या हेल्थ केयर में वो करते हैं, वो अर्ली स्टेजेस में ट्रीटमेंट ना होने से वो ओवरऑल ज्यादा ही करते हैं। बट प्रॉब्लम इज कि अवेयरनेस बहुत कम है। सेकेंडरीली हम लोग एज एन इंडियन कल्चर रोटी कपड़ा और मकान में इतने बिजी रहते हैं कि हेडेक को तो माना जाता है, जैसे स्पाउस हेडेक हो गया, अरविंद सर ने बोला, या बस हेडेक है, कुछ करना नहीं है। सो दीज आर द बिगर प्रॉब्लम्स। तो हम लोग की प्रॉब्लम इज अवेयरनेस। पेशेंट डजंट रिकॉग्नाइज रियलाइज कि ये हेडेक जो है वो एक प्रॉब्लम है, रादर देन दे जस्ट टेक इट एज ए सिम्टम। हाँ हेडेक है, मैंने खा लिया सेरिडॉन, खा लिया क्रोसिन, खा लिया, ठीक हो गया, क्या ही हो जाएगा हेडेक से।
Correct. And I think so, यही behavior change है तो every individual who is listening to our conversation and specifically जो migraine patient है उसने ये attitude change करना पड़ेगा so that they can get rid of it, have a proper treatment, good proper consultation treatment, and you know they can live a healthy and less complex life ahead. And like you said, if we calculate more or less the amount becomes the same, or maybe it is a bigger burden because you know it affects their daily life, work, and other things as well. So moving on from from understanding the disease now to understanding that how science is transforming the migraine care. Arvind sir, we would like to understand that over the last decade, migraine research has advanced tremendously because of the innovations and research that is available. So our understanding of migraine has evolved significantly from vascular disorder to a complex neurological disease. So what major scientific advances have shaped the current migraine management in our country?
थैंक यू सिमरन, थैंक यू वेरी मच। एडवांसेस से पहले, सबसे पहले जो सबने बोला है कि माइग्रेन को एक बीमारी समझें, रादर देन कोई आम हेडेक नहीं समझें। और जैसे हमने बात किया कि इट्स अ लाइफस्टाइल डिजीज, है ना। अगर हम अपनी लाइफस्टाइल अच्छी रखेंगे तो बेसिक्स की जगह पे रहेंगे, वो कहीं नहीं जाएंगे। और जो दवाइयाँ अभी तक माइग्रेन के लिए काम आ रही थी और वो अगर पेशेंट को सूट करती हैं तो वो देना बंद नहीं करना चाहिए। देर आर मेजर एडवांसेस एंड अंडरस्टैंडिंग ऑल्सो, जैसे आपने वस्कुलर उसके लिए बोला कि इट हैज चेंज टू मोर कॉम्प्लेक्स फिनोमिना। तो जो ट्रांजिशनल वस्कुलर फिनोमिना होता है, जो ट्रांजिशनल कॉम्प्लेक्स होता है, वहाँ से इन्फ्लेमेटरी मार्कर्स रिलीज होते हैं। सब्सिक्वेंटली आपने देखा होगा कि जिनको क्रोनिक माइग्रेन रहता है कि वो, मैं तो अपनी बात तो क्या करूं, पर बाल भी नहीं बना सकते, वो कंघी करते हैं तो उनको कंघी भी नहीं डाल सकते अंदर, जिसे हम सेंट्रल सेंसिटाइजेशन बोलते हैं। पहले पेरिफेरल होता है, फिर सेंट्रल होता है, वो दे कैन नॉट इवन कोम देयर हेयर, इतना ज्यादा पेन होता है। और वो पीछे पूरा सिफेल्जिया कहते हैं उसको, पूरा नेक तक भी नीचे तक जा सकता है। तो सबसे पहले तो वो समझना पड़ेगा कि इस डिजीज के लिए हमें थेरेपी के लिए जाना है। ओवर द काउंटर ड्रग लेने के कारण वो ड्रग इंड्यूस भी हो जाता है। आई एग्री, देर आर थेरेपीज, पर अगर उसे अर्ली ट्रीट कर दिया जाए तो वो जो थेरेपीज लाइफ बहुत सालों से चली आ रही हैं, जिसमें प्रोपेनोलॉल इज द ड्रग ऑफ चॉइस, दैट आल्सो एक्ट्स वेरी गुड। हम सारे जितने भी एक्सपर्ट यहाँ बैठे हैं उनसे आप पूछ लें, जो पेशेंट उस पे कर रहे हैं वो बहुत अच्छा करते हैं। पर क्या होता है कि मैं लाइफ लॉन्ग एक हेडेक के लिए तो दवाई नहीं ले सकता, है ना। और मैं लाइफस्टाइल मॉडिफिकेशन भी नहीं कर सकता, मैं रात को जगूंगा ही जगूंगा, है ना। मुझे खाना नहीं खाना है, मुझे उपवास या व्रत करना ही करना है। एंड यू नो पीपल आर डूइंग फास्ट फॉर 9 days बट दे आर नॉट हैविंग हेडेक बिकॉज दे आर नॉट माइग्रेनस, राइट। सो ये फैक्टर कहीं हटते नहीं हैं किसी भी ट्रीटमेंट से, दे आर मोर इम्पॉर्टेंट फॉर एनी पेशेंट। बट इफ दे आर, इन सारे ट्रीटमेंट के बावजूद भी अगर आप नहीं ट्रीट हो पाते हैं तो देर आर थेरेपीज विच हैव कम, लाइक सीजीआरपी के आगे आप फर्दर डिस्कशन करेंगे ट्रीटमेंट के अंदर। सीजीआरपी एंटागोनिस्ट आए हैं, ओरल टैबलेट्स भी आ गई हैं जिसके अंदर जीपैन, ट्रिप्टैन, बहुत सारी ड्रग्स आई हैं जिससे कि हेडेक एकदम दूर हो जाता है। इवन बोटॉक्स एप्लीकेशन, अगर बहुत लंबे समय तक हेडेक रह रहा है और पेरिफेरल से सेंट्रल सेंसिटाइजेशन होता है और हाथ लगाने पे भी दर्द होता है, तो बोटॉक्स भी एक तरह का ट्रीटमेंट आया है। पर दोज आर द थेरेपीज व्हेन यू फेल द इनिशियल थेरेपी। But definitely for acute attacks also, before only there were triptans, now there are many other drugs which has come, which are there for the treatment. So you should not get disheartened if you have a severe headache. पर आपको ये समझना पड़ेगा कि आपको महीने के 15 हेडेक के बाद हॉस्पिटल नहीं जाना है, स्पेशलिस्ट को नहीं मिलना है। आपको 1 से 2 डिसेबलिंग हेडेक्स अगर हो रहे हैं, डिसेबलिंग मतलब एक हेडेक भी 3 से 4 दिन चल रहा है, जो आपको हॉस्पिटल या आपके घर, आपके काम पे जाने पे रोक रहा है, तो आपको डेफिनेटली, क्योंकि मोस्ट ऑफ द एब्सेंटीज इफ यू सी ऑफ द यूएस प्रेसिडेंट आल्सो वाज बिकॉज ऑफ द माइग्रेन, पुराने जितने भी। और अच्छी बात यह है कि माइग्रेनर्स मोस्ट ऑफ द टाइम इंटेलिजेंट होते हैं, है ना, ये बात कहना चाहूंगा। तो वो ज्यादा इंटेलिजेंस में अपना ट्रीटमेंट खुद कर लेते हैं, या फिर कपड़ा बांध करके सो जाते हैं और सोने के बाद उनका हेडेक ठीक हो जाता है। पर उन सभी दर्शकों को कहना चाहूंगा कि ट्रीटमेंट अवेलेबल है, पर लेटेस्ट ट्रीटमेंट से पहले अपना नॉर्मल ट्रीटमेंट, जब हेडेक, दो डिसेबलिंग हेडेक महीने में हो रहे हैं या एक भी हो रहा है, तो आप एक्सपर्ट्स के पास जाएं और ट्रीटमेंट कराएं। थैंक यू सिमरन।
थैंक यू सर। आई थिंक इतने अच्छे से जो हमें माइग्रेन के बारे में समझ में आया है, दैट हाउ वी आर अवॉइडिंग इट, हाउ वी शुड नॉट अवॉइड इट, व्हाट आर द थेरेपीज अवेलेबल एंड हाउ वी कैन टेक केयर ऑफ दिस। I think this is something which all our audience must need to understand and act quickly. Like you said कि एक या दो से ज़्यादा अगर हमें ऐसा हो रहा, हेडेक्स हो रहे हैं और उतने लंबे टाइम तक खिंच रहा है, I think we should not delay it. We should go to our experts for consultation as soon as possible, so that we can, we can get rid of this and lead a good, healthy, happy life ahead. Building on that and moving to my next question to Dr. Achal. So, one of the biggest development attracting global attention is the emergence of CGRP targeted therapies, which Dr. Arvind also highlighted on. So CGRP targeted therapies are being viewed as a breakthrough in migraine treatment. So, how are these therapies changing preventive care strategies and the patient outcomes as well? How? Dr. Achal, can you hear me?
So, am I audible now?
Yes, sir, you're
Yes.
audible.
Yes, I can hear you. Am I audible? Yeah, okay, all right.
Yes,
Yes, sir.
sir.
So, the disease is there for years.
Yes, sir.
And people have been trying to treat it by various methods. Several of medicines are available which are used for the purpose of prophylaxis. However, with the development of CGRP drugs, which has actually, I will say, changed the scenario. There are several things which has come up with CGRP. One is, and also it was the problem with previous drugs, that you were supposed to take it on daily basis. Patients were missing, and this is where you are not going to take it on regular basis, not daily. You have some days, after that it will be given again, many days. So adherence is more, like if you are advising some beta blocker which has to be taken very often, they will forget, and then come back with the headache, or it is not improving, the prophylaxis is not working. The same is not true with this. Number one. Number two is that there is no problem of drug and drug interaction. Several drugs you need to avoid because there will be some interaction, patient is having some other disease at those medicines. So that is not happening with this. So these are some of the things which are very important. And not only that, some of the newer medicines can also be used in acute state. Whereas, whereas earlier you medicine, you have your actually is nowadays having more, I will say, more of medications which he may use to treat these patients. And not only the adherence, of course, has increased. The only problem with the newer medicines is the cost. And as Dr. Arvind and Dr. Vineet were also saying, that many people avoid to go to the doctor and give take some medication and also spend money on this and that. People are not interested. So what you need is to increase the awareness. There are, the most problematic thing is with migraine, that आपका दिन बर्बाद हो जाता है, 2-2 3-3 दिन. Your working hour is gone, to you or was supposed to be done by you, you have failed in doing that. So things are very important. So that's why CGRP is a very big development, I'll say. Thank you.
Thank you, sir. Thank you so much for highlighting on the new therapies and the solutions we have. And I think uh, the most important part we are lacking is the awareness. If we can aware our public, I think half of the we achieved half of the way, and the rest is left is they just have to go to a doctor to get it treated. Moving on to my next question, Dr. Ashish. So, medicine today is becoming increasingly personalized with the help of precision medicine, genomics, and the advanced research we have. So, and migraine management is no exception into this case. So, if we have to understand that how feasible is precision-driven migraine management today, particularly in tailoring therapies based on patient's phenotype, triggers, and disease pattern, basically based on the patients which come to a doctor and on their different symptoms.
So we, those who treat migraine, all neurologists and headache specialists, we always try to give medicines on the basis of the phenotype, triggers, and the phenotype of the headache. So whenever we are giving an acute medication, we look how quickly the headache peaks. So if the headache is peaking in, let's say, within 10 to 15 minutes, we would prefer a non-oral route, probably a nasal medication or a subcutaneous one. Subcutaneous is not available in India now. If there is a lot of vomiting, we would probably like to give a dispersible tablet, which they can just keep under the tongue and it will dissolve and it will get absorbed. And depending upon the severity again, so for mild to moderate headaches, the usual NSAIDs can be given, but for severe headaches, they won't work. The patient will not get a good relief in 2 hours, and then the headache may recur, and all this will lead to further chronification and overuse of medication. So this is how, on the basis of phenotype, we are trying to give the acute medication. For the prophylaxis to the medication, again, we look at the phenotype. So depending upon whether it's chronic or episodic, whether the headache is more than 15 days per month, what are the associated features? Suppose there is a basically vestibular migraine. So the medicine will change for that. If there is a significant vertigo, we'd probably like to give some calcium channel blocker. And suppose it's more chronic migraine, probably we would like to use CGRP antagonists, as sir just said, earlier in patients with chronic migraine, those who have medication overuse. So if they're abusing medication, then probably the CGRP, botulinum toxin, they will be more effective, and probably we will be trying to use them earlier rather than waiting and letting the migraine chronify further. So the basically, well, and the comorbidities. So patients with hypertension, they will probably benefit from ACE and ARB like candesartan or telmisartan and beta blocker. If they have a comorbid depression, then an antidepressant would be probably better. And if they are overweight, then probably we would like to avoid valproic acid and probably give topiramate. So this is how phenotype comorbidity-based precision medicine, this has always been practiced. Now, there are some biomarkers, but I think that is quite far off presently, especially in India. We don't have those things available. So basically what we are doing is phenotype-based precision medicine.
Then I think so. Slowly and gradually, the markers you said might be available in our country also for better treatment approach. And currently, also with the new technology and the research, we have a better treatment option, as you just mentioned, as compared to the earlier times. And I think that is a light of hope, which we should not, we should look forward to. Moving on to
Yeah.
my next question. So, to Dr. Vineet. So, technology is also beginning to reshape neurological care. So, building on to what Dr. Ashish said, what role can biomarker, neuroimaging, and digital health technologies play in enabling more accurate diagnosis and long term treatment monitoring we can have?
Uh, so as Dr. Ashish said, we don't have too many biomarkers as of now in India. Like as such, migraine doesn't have too many biomarkers as such. Like even when we compare across the world, ऐसा नहीं है कि बहुत सारे बायोमार्कर्स हैं जो हम एमआरआई इमेजिंग या न्यूरो इमेजिंग कराते भी हैं. उसका मेन पर्पस होता है कि जो माइग्रेन के ऑल्टरनेटिव इटियोलॉजीज हैं उनको रूल आउट करें. और कई बार माइग्रेन एटिपिकल होता है, जैसे यूजली तो हेडेक होता है, बट बहुत बार आपको हाथ पैर में झंझनाहट हो सकती है, दिखने में दिक्कत हो सकती है, तो उस टाइम में हमको ऐसा भी लगता है कि शायद स्ट्रोक होगा या कोई और डीमाइलिनेटिंग इलनेसेस हो सकती हैं, इसके लिए कराना जरूरी है। बट फ्यूचर में आई थिंक हम में से किसी ने भी शायद 15 साल पहले, मैं तो बहुत छोटा था, बट 15 साल पहले किसी ने ऐसा सोचा नहीं होगा कि हम लोग इस समय बैठ के ये वेबिनार कर रहे होंगे इस टाइम पर। सो फ्यूचर इज ऑफ एआई। सो आई थिंक एक बहुत बड़ा रोल आने वाला है वियरेबल डिवाइसेस का, जो आपको आपके माइग्रेन अटैक होने के पहले शायद आपके बीपी, आपके पल्स को चेक करके या कुछ इस तरीके से अपने ब्लड सर्कुलेशन को चेक करके आपको बताएंगे कि माइग्रेन ट्रिगर होने वाला है। या फिर दूसरे तरीके से आप देखें कि आपको माइग्रेन के कोई पर्टिकुलर ट्रिगर है और अगर आप एप्पल वॉच पहनते हैं, आप अपने एप्पल वॉच का जो साउंड का ट्रिगर है उसको लोअर लेवल पे सेट कर दीजिए। तो उससे जैसे ही उस लेवल के ऊपर साउंड जाएगा, एप्पल वॉच आपको बता देगी कि नाउ द नॉइज इज बियॉन्ड द लिमिट दैट यू हैव सेट इट एंड यू कैन अवॉइड दैट ट्रिगर, एंड वी कैन यूज इट इवन नाउ विद एप्पल वॉच। सो sooner there'll be more wearable devices which will tell us okay ये sound intensity ज्यादा है, ये light intensity ज्यादा है, एंड देन आप गैजेट्स का यूज करें, जैसे फोन का यूज करके। अब यूजुअली हेडेक डायरी मेंटेन करना बहुत मुश्किल है, लेकिन स्मार्टफोन सबके पास है। आप हेडेक डायरी को अपने आराम से एंटर कर सकते हैं, अपने हेडेक एपिसोड्स को, कि मुझे कब हेडेक हुआ, मैं उसके पहले क्या कर रहा था, मैं उसके बाद में क्या कर रहा था। अपने स्क्रीन टाइम को देख सकते हो, सबसे इंपॉर्टेंट है अपने स्लीप टाइम को। जैसे मैंने अपने फोन में कर रखा है कि मेरा स्लीप टाइम ये है, मैं हर हफ्ते अपना स्लीप का रूटीन देखता हूँ कि मैं कितने घंटे मेरा स्क्रीन टाइम था, कितना घंटा मैंने नींद ली प्रॉपर। तो ये जो सारी चीजें हैं, जो गैजेट्स हैं, टेक्नोलॉजीज हैं, अगर हम उनको यूज करें तो बहुत सारे माइग्रेन के ट्रिगर्स को हम मैनेज कर सकते हैं। एंड मोर इम्पोर्टेंटली, जब हम ट्रिगर्स मैनेज करते हैं, एंड वील ऑल एग्री टू दैट कि ऑलमोस्ट 70 to 80% ऑफ माइग्रेन अटैक्स आर ट्रिगर बेस्ड, एंड इफ यू जस्ट रिमूव द ट्रिगर्स, 70-80% तो वैसे ही ठीक हो जाएंगे। तो ये जो टेक्नोलॉजी है, दैट इज गोइंग टू हेल्प इन अ बिग वे in coming in times to come in preventing these attacks.
I think so. जो आपने अभी explain किया that how we can use this modern technology, the wearable devices or the mobile phones, which we have a lot of feature. That's how we can record कि हमें trigger किससे हो रहा है, हमें कितने headache episodes हो रहे हैं. I think this will definitely help us to get better diagnosis and yes, better treatment as well. This will always anyways help the doctors as well to see what things are triggering the patient, how they can avoid it. Even if okay, let's say it could be due to a bright light, so a bright light can be avoided, and what else is required. So I think these will definitely help us to identify and understand the disease better according to patients. Thank you so much, sir, for shedding light on this. This is a quite important aspect. My next question is to Dr. Arvind. So, we know that medication is certainly important, but comprehensive migraine care extends beyond prescription. So, it is not limited to prescription only. So, beyond pharmacological therapies, which lifestyle behavior or integrative interventions currently have the strongest evidence in improving migraine outcomes? So, you're on mute, sir. Wait, I'll unmute you.
Yeah, I'm sorry for that. Yeah, thank you, Simran. Thank you very much for that question. Basically, patient-centric approach, right? Treatment, though there are a lot now where you can treat at the different stages of migraine. अगर हम पेशेंट सेंट्रिक देखें और लाइफस्टाइल के लिए, जैसे आपने बहुत अच्छा बोला, जो ये लाइट्स होती हैं, डिस्को लाइट्स होती हैं, जो माइग्रेनर्स होते हैं, वो उसको अगर देखें, और even if you consider the people have a they are shopping freak, but when they go out in the shopping in the sun and they come back, they have headaches, right? तो
Yes.
सिंपल चीजें टू अवॉइड, बेसिकली जो लाइफस्टाइल मॉडिफिकेशन है उसमें, कि आप डार्क ग्लासेस पहन के, जैसे सन को देख के अगर आपको हेडेक होता है तो आप डार्क ग्लासेस पहन के जाएं। डॉक्टर विनीत ने बहुत अच्छी बात बोली अबाउट द हेडेक डायरी, है ना, वो मेंटेन करना बहुत जरूरी है कि आपको किस चीज से होता है, किस चीज से नहीं होता है, ट्रिगर्स क्या हैं आपके, और रिलीफ किससे मिलता है आपको। तो मैं अपने एक दोस्त की बात बताना चाहूंगा कि जो गेस्ट्रोएंटरोलॉजिस्ट है, उसको आप फूड आइटम्स देखो, आप वेस्ट में जाते हो तो वाइन लिखते हैं, डिफरेंट फूड प्रोडक्ट्स लिखते हैं, मायोनीज लिखते हैं, चॉकलेट्स लिखते हैं, पर इंडियन सेटिंग्स में उसको इंडियन वे में जाना बहुत इंपॉर्टेंट है। जैसे उन गेस्ट्रोएंटरोलॉजिस्ट को पनीर खाने से हेडेक वो होता था, राइट? तो ही आइडेंटिफाइड हिज फूड,
Hmm.
जो कि एकदम खाते ही नहीं होता है, आफ्टर द गैस्ट्रिक एम्पटिंग उसके बाद शुरू होता है। जैसे शुरू में डॉक्टर विनीत ने बोला था कि गैस बनने वाला फिनोमिना समझते हैं कि उसके कारण उनको सर दर्द हो गया, कि गैस कहीं से तो बाहर निकलेगी तो वो सर में चढ़ जाती है। ऐसा बिल्कुल भी नहीं है।
Correct.
गैस्ट्रिक मोटिलिटी डिक्रीज हो जाती है माइग्रेन के वक्त, इसलिए आपको फुलनेस भी फील होती है आपके अपर एब्डोमिनल पार्ट में, और आपको माइग्रेन अटैक शुरू होता है। तो लाइफस्टाइल मॉडिफिकेशन में ट्रिगर्स जैसे फूड, आपकी स्लीप हैबिट्स, आप
Hmm.
अगर रात को नहीं जग सकते तो नहीं जग सकते, आपको खाना टाइम से खाना है, आप फास्ट नहीं कर सकते तो नहीं कर सकते, उसमें कोई कहने की बात नहीं, आप दूसरों को देख के चीजें नहीं कर सकते। तो दीज आर पेशेंट सेंट्रिक अप्रोच, कि आपको उनको पता करने पड़ेगा एज ए डॉक्टर भी कि उनको क्या चीज अफेक्ट कर रही है, वो चीजों पे आपको फोकस करना पड़ेगा, है ना, और वो चीजें उनको चेंज करनी पड़ेगी। और फिर बात आती है थेरेपीज की, वो भी बहुत इंडिविजुअलाइज्ड होती है, कि एक कारपेट थेरेपी नहीं है। जैसे डॉक्टर आशीष ने बहुत अच्छा बोला था कि इसमें वेलप्रोएट नहीं दे सकते, उसमें दे सकते, वो हम सब करते हैं, पर वो इंडिविजुअलाइज अप्रोच बहुत ज्यादा इंपॉर्टेंट है। तो
Yes.
डाइटिशियन के पास जाना है तो डाइटिशियन के पास जाएं आप, जो भी आइडेंटिफिकेशन करना है। द मोस्ट इंपॉर्टेंट थिंग विच आई फील, विच डॉक्टर विनीत ट्रैक, इज स्लीप, है ना।
Yes.
स्लीप इज अ वेरी इंपॉर्टेंट फैक्टर। और ये मत सोचिए आप कि आप कम सोने से ही आपको हेडेक होता है। इफ यू आर ओवर स्लेप्ट ऑल्सो, देन ऑल्सो हेडेक कैन हैपन। कि मैं 10 घंटे सोता हूँ साहब तो भी मुझे सिर दर्द हो जाता है, तो ऐसा नहीं है। यू हैव टू आइडेंटिफाई योर फैक्टर्स, एंड डॉक्टर हैज अ जॉब टू डू दैट एंड गिव द ट्रीटमेंट। एंड यू नो दैट वन एक्सपर्ट हैज जॉइंड विद अस, डॉक्टर अंशु इज हियर। डॉक्टर अंशु, वेलकम। नमस्कार।
हेलो, नमस्कार। कैसे हैं अरविंद जी?
बिल्कुल बढ़िया, थैंक यू।
बढ़िया।
Good
सिमरन
evening,
टू यू।
Dr. Anshu.
गुड
Thank you so much,
इवनिंग।
sir.
गुड
Good
इवनिंग।
evening, Dr. Anshu, for joining. To our viewers, I'll just quickly introduce Dr. Anshu Rohtangi. He's Vice Chairperson, Department of Neurology at Sir Gangaram Hospital, New Delhi. Thank you so much, sir, for joining.
थैंक यू।
Thank you, sir. So we were discussing upon the medication apart from the prescriptions we have, and we discussed few points. So I will just quickly take a question from you. Focusing on the future of migraine care and patient empowerment. So, healthcare today is gradually moving towards prevention rather than simply treating the symptoms. So, if you could tell us that how can healthcare systems move beyond episodic symptom relief towards more preventive, patient-centric migraine care pathways? If you can explain us on that, sir.
Okay. So if I if I talk about migraine, I firmly believe that migraine is something which is something that you are born with, and something that can be corrected partly by lifestyle. So some of the triggers of migraine, I think we there is not enough awareness. We always talk about medicine, 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 but we are not creating awareness about what exactly is migraine and how can we prevent it. A lot of these episodes can be prevented by simple measures like having a regular sleep pattern, not missing a meal, avoiding uncertain exposure to sunlight or cold, or covering your head. So I think we have to basically educate the people that migraine is a disease where you can prevent some of these episodes from occurring if you take proper precaution, eating meals at regular times, sleeping in times, avoiding some of these stresses like too much of physical stress or emotional stress. So some of these factors are correctable, and to identify uh, which are the triggers that you have. Like some people on taking wine or chocolates or even so they would have headaches. So I think that is very very important. I think if we educate the patient, we will empower them. We'll give them that power. They will let to know that I can prevent some of these episodes from occurring if I eat properly, I sleep properly, I avoid certain things which are triggers. So I think that is very very important. That is the first part of the therapy. The second part is, I think that the message should go across that if we have a good prevention of migraine, so what we see is that initially all migraines are episodic in nature, and ultimately, if they're not properly managed or treated, they go on to become a chronic migraine or a medication overuse headache, which are much more difficult to treat. So I think the awareness should be not only in the physicians, general public, that migraine is a preventable disease. It is something which can be treated and managed. So I think migraine prophylaxis is very very important, and fortunately we have now a number of drugs which can be used for prophylaxis, and so I think that is another important point. And there's a very big myth in the public that if somebody is born a migrainer, he or she is likely to remain a migrainer through life. I think that has to be changed. That nihilistic attitude that migraine cannot be treated or cannot be managed. I think that is very very important, because most of the people, they don't turn up to doctors that they won't be able to help. They run to other centers like a homeopathic or an Ayurvedic or all that. So I think a combination of patient education, preventive strategy, and medication, I think will go a long way in helping these patients.
So, as you just clearly focused on the patient education, that if we educate patient right about their triggers, about their lifestyle, and what is helping them when what is actually increasing the migraine. So, in your experience, when patient comes to you, when they are properly educated, they take care of all these factors, and they actually want to move towards, for the treatment. Basically, this is one of a factor to treat migraine. So, how does this critical patient education helps in improving the treatment adherence, reducing stigma, and encouraging long-term disease management?
So I think that it makes a difference, because my basic dictum always is that whenever a new patient of migraine comes, it is better to spend some time with the patient to educate the patient. I think that is very very important, and because a patient who comes with a very frequent migraine is always worried that I may not be having a brain tumor or anything, or a brain hemorrhage or some kind of a thing. So I think patient education and awareness is very very important. Unfortunately, most of us who are sitting here are very very busy people, and we don't have that time to really educate these patients so well. So I think if we have somebody who's maybe a counselor or a person sitting with us who can educate these patients about the do's or do nots of migraine, and tell them something about the medication, I think that would go a long way.
Definitely. So I think I think the approach where we can have experts of multiple experts can help us actually have a better pathway to treat this migraine. Thank you so much for this response, sir. I would like to take my next question, Dr. Achal. So, digital health is becoming an integral part of chronic disease management, like Dr. Vineet also highlighted on the technological part. So, on the wearable technologies which are rapidly expanding, how can these tools help the patient better identify triggers and participate actively in their own care?
So in that, most important would be, Dr. Vineet pointed out, I remember, that they should have a diary. And these days, you can, I mean, instead of having a physical diary, you can keep this in your mobile or laptop or whatever system you are using. It's very important not only to mention the days they are having a headache, and also they should be focusing on the precipitant or trigger factor. What were the trigger factors? Sometimes they don't remember, and that's why they are not able to act on that. So if you remember the trigger factors, you can act. I always tell the patient that you only know the trigger factors. I can tell you some, and you can choose one of them, two of them, or three of them, but precisely you are the person who knows what are the triggers in you. There are some common triggers which we all physicians know, will be asking you. So this is very important. So in that sense, they can write on the records that this is the trigger factor. That's what I said, that they can use the mobile. Uh, the use of AI is coming up, and Vineet also suggested that maybe we will have sometimes that now some of the pre headache phenomena are happening, and you are going to have headache. It may be predicted. So in that sense, it will help you out in managing yourself, and the advices given by the doctors what has to be done in that time, you can immediately apply that to you, and maybe you are uh, having no headache in that particular episode, or very mild headache which will improve by itself, not requiring any therapy. So AI is definitely coming up, and I'm sure the time is not very far where AI will be helping the patients, and AI is helping the doctors as well. I will suggest that the rational use of AI is very important. We have been speaking everywhere that we should not be dependent on AI, rather use the AI. Thank you.
Thank you, sir. Thank you so much for highlighting the judicial use of AI and how technology is helping us. Anyways, we know that AI can never replace the human touch. AI can never replace our doctors who are actually concerned and who hears our problems, understand the disease, and then give us a treatment solution on this. Moving on to my next question, Dr. Ashish. So, migraine often does not exist in isolation and can significantly affect the emotion well being as well. So, it frequently overlaps with anxiety, depression, sleep disturbances. So, how important is this multidisciplinary mental health integration into migraine management, specifically in today's era where I believe depression, anxiety, or sleep disturbances are quite often to specifically the young generation.
Yeah, so this has already been discussed. So, sleep is a very important thing. Dr. Arvind already said not only less sleep, more sleep also. So, probably the best thing is not only the time, duration of sleep, but the timing of sleep. So, one should try to sleep at 11 and then get up at 7. That is the best time. And if you're, see, migraine patients, they can't tolerate too much chaos in their lifestyle. That is the major thing. So if they are sleeping late, getting up late, this even if they are sleeping for 10 hours, they can have their problem. Then another thing is obstructive sleep apnea. That is very an ignored thing, which underappreciated, and it can worsen migraine, and especially in older people. So if there is an increase in migraine frequency in the later part of life, as sir had already told, it decreases as we get older. So then you should always inquire about sleep related problems, so whether they are excessive snoring or they are getting up at night with sleep with breathlessness and all. And regarding anxiety and depression, these are very comorbid. And the problem is that as the headache worsens, they become more chronic. The patients become more anxious. They become more depressed. So this has to be addressed every time. They may not be forthcoming. So the physicians should ask them regarding whether they have symptoms of depression. And obviously, a multimodal approach is required. So there some antidepressants work both for migraine and for depression. Anxiety can be managed, but obviously they will require some type of cognitive behavioral therapy if they are not responding well to medicines. Medicines are not always the correct answer to anxiety and depression, and they would probably require some psychological help from psychologists or cognitive behavioral therapy. So migraine, as Dr. Anshu has also said, it requires a multimodal management. So it's not just the neurologist who is going to see, but other people like the psychiatrists, psychologists, they also need to sometimes get involved.
So I think so that interference is required, and that gives us a complete and clear picture in terms of treating this. So thank you so much for highlighting and stressing upon this important aspect. My next question is Dr. Vineet. So where we talk about AI technology and innovation in neurology that continues to evolve rapidly. So looking ahead, if I have to understand from your side, which innovations, whether in therapeutics, diagnostics, or digital medicine, do you believe will redefine the migraine care over the next 5 years?
So I think one of the very important changes that are going to take place in next decade or so is the precision medicine. So we'll be more precise in deciding what medicines to give. For example, CGRP molecules, like they are actually precise. They are targeting where the drug should target. Coming on to other advances, such as we have been discussing about role of AI, wearable devices, getting the triggers. The other thing that technology can do is do a lot of teleneurology, and all of us would agree that all chronic diseases and the burden of chronic diseases lies more in the rural India than in the urban background, and there is a huge dearth of super specialists in a rural part of countries, and telemedicine and teleneurology for that sake actually can bridge that gap when patients can, and then even like social media is one of the very important this thing. I've just made a reel. My patient asked me, डॉक्टर मुझे दर्द होता है पर मुझको ना मुझे मुझे एसिडिटी होती है सर, मुझे एसिडिटी की वजह से दर्द होता है, and that gave me the context and I made a reel about headache and acidity. तो देन आई मेड अ रील, एक्चुअली वो आपको एसिडिटी की वजह से हेडेक नहीं होता, आपको हेडेक की वजह से एसिडिटी होती है, एंड दैट रील वेंट वायरल, क्लोज टू 2 million views. So this is also use of social media technology, how you go about your business. It's not just one thing, as all of us are emphasizing that it has to be a multimodal thing. Obviously, AI or any such thing is not going to replace a doctor. It can replace a doctor who just prescribes drug, but it can never replace a doctor who talks to patient, who counsels the patients, who asks the questions. जब आप पेशेंट से क्वेश्चन पूछते हो, सवाल पूछते हो, अगर आप 15 मिनट हेडेक के पेशेंट के साथ लगाओगे, तो then you will find a lot of solutions. And that ways I think that helps. I think once you start talking to the patient, and remote availability through WhatsApp and all of that, if you combine all of that, in total the picture is going to evolve fast. And one of the other thing that will come is, for example, if you have headache, now you put all your symptoms in chat gpt. Chat
Yes.
gpt, almost 90% likelihood is will tell you that you have migraine and not any headache. जिसको हम लोग कोई सिर दर्द सोच रहे थे, हो सकता है चैट जीपीटी की वजह से हमें पता चले कि वो हेडेक हेडेक ना होके वो माइग्रेन है. So that is how technology will help us in bridging this gap that is there.
Very rightly mentioned, sir, and a very right example quoted that that how technology is helping us to identify what all these symptoms can be of, and I think the next step is to, when you have a vague idea, let's say an idea of that it could be migraine, then the right step is to go to a neurologist and consult it for what exactly it is, how it triggers, and what are the treatment options which are available. So moving ahead to my next question to Dr. Arvind. So we know that India is a diverse country, and with every diversity, where the region changes, we crosses the border, things vary. So are there any notable regional variations in migrant prevalence according to environmental triggers or healthcare access across different parts of India?
Thank you, Simran. See, you told about the, if you see the literature and you Google it, the India as a global market, if you see about the migraine, it is 17% is being told for the West. It is more than 25% what is in India is. And four of my esteemed experts are sitting from Delhi NCR, and I'm the odd man out here. It is higher in those regions, has been said, and even in the south, basically. But what I believe, I come from Gujarat, I'm from Ahmedabad, and there are only two climate here. One is hot, another is super hot, right? So it is very clear where the temperature is hot, if it is a tropical climate, and you go out more out in sun, and if you are not wearing the dark glasses, you see many people who go for shopping come to me with headache, right? I went for my favorite job, that is shopping. I came with a headache, right? So regional variation in India, here we are unified as India. All are having the headache. You are talked about the access. That also I will say that rural and urban access for stroke may be different, but migraine
Yes.
it is same because people don't go to the doctor. It is rural or urban. Urban are more smarter. They do all the regional therapies, all the Ayurvedic therapies and different therapies, and they are also. I'm not an expert in those pathies, right? But having said that, rural and urban also, I don't feel difference. Sometimes rural have more sense of sleeping and all that, and urban stress. And most important thing in urban is the air pollution.
Yes.
That is another factor which adds to it, right? And how much difference in rural and urban in the mobile is. We tell that the mobile hygiene is very important. Keep your mobile on the side, not on your bed. It should be kept far away from you. But most of the reels are seen at the night. Vineet Banga got 2 million hits because of that, because people seeing at the night and they're having a headache next day. That is how the neurologists are getting their business. Stop giving neurologists a business and stop seeing the reels at the night for 2 hours and sleep after seeing the reels. Right? So these are the factors which are very important to keep a mobile hygiene, sleep hygiene, which are very important. And I feel there is not much of regional variation. Tropical climate is tropical climate. It is there, urban and rural, both the places, because of this industrialization, or the main thing, which is the box, small box in your hand. And the screen has gone bigger. You have seen, right? It was BlackBerry, it was Nokia, small screen. All the screens are big, right? And with the bright light, you keep the light on the highest mode so you can see the video in the ultra quality. That again, it is just like a disco light for you, right? When you see the reels. So I'll rest my case here. Thank you very much, Simran. And it
Thank
applies to me also. Yeah.
Thank you so much, sir, for candidly explaining us this, and that how our lifestyle, specifically the urban lifestyle, watching reels at night and having a proper phone hygiene habit can, help us reduce episodes of migraine, and what all things affect, and specifically highlighting that the regional differences does not play an important role in such case. Moving on to my next question, Dr. Anshu. So, migraine affects much more than physical health. It impacts education, career, mental health, and productivity. So, given its impact on productivity, mental health, quality of life, should migraine receive a stronger recognition within the national public health and non-communicable disease framework? Because we know that India has moved from the communicable diseases to the non-communicable diseases, which are more of due to lifestyle.
Yeah, I would definitely agree with that. So any migrainer, if you talk, who has possibly a high frequency episodic migraine or a chronic migraine, what happens is that the headache really impacts their working, education, in all spheres of life. So if you look, I think the number of days that they're not working is very significant. And in fact, actually, if migraine or headache is one of the commonest neurological problems that affects the general population. So if I look at across the spectrum of problems that neurologists see, I think migraine is the commonest one. In fact, it is the bread and butter for most neurologists. So I think the numbers are really staggering, and the number of days that one loses because of different reasons, especially migraine, is much more than any other disease that we talk about. Of course, there are more serious diseases like stroke, epilepsy, but I think migraine, if you look, is a much more common disease. So I think if we talk about the non-communicable disease, it is important that migraine be treated in a proper fashion. So these days can be prevented. This disability days can be prevented. I think it's a good idea.
Thank you so much, sir, for
I would
highlighting
just
this.
add one more point. Just I think one thing that is very common is a little bit of miscommunication that patients have. A lot of people who are come to us with migraine, they often land up with an orthopedician or a physiotherapist because of cervical. They call it a cervical pain or migraine. And second is that a lot of them end up with a gastroenterologist or an ophthalmologist because they think that it is an eye problem or a stomach problem. I think that awareness has to be there. Migraine itself is a disease which has to be treated by neurologists. And unfortunately, the medical curriculum for most of the MBBS, it does not talk about migraine. It talks about other big things, but one of a very common neurological problem it is not taught about. I think that is very important. That even the doctors, they don't read much about migraine in the MBBS curriculum.
So I think so. What you're trying to communicate is we need more such awareness in terms of to the healthcare clinicians and the public as well, so that we can go hand in hand in terms of treating it. Moving to my next question to Dr. Ashish. So, as we spoke to Dr. Anshu and Dr. Arvind regarding the accessibility and how it should be at a national level to recognize this and have a stronger uh, plan for this. So, accessibility remains one of the biggest healthcare challenges across the country. So, what key healthcare delivery gaps still exist in ensuring equitable migraine diagnosis and treatment across tier 2, 3, and the rural regions as well?
So to continue where Dr. Anshu just left regarding medical education, as Sir said, and I would just reiterate that MBBS in even at MD level, headache, migraine, they are not taught properly. Even the residents and the MBBS students, they are not bothered about reading because they know this is not going to come in the exam. The curriculum is too much exam oriented, less of practical oriented. And that is the reason why this so large healthcare gap exists. See, a neurologist can't go to the rural areas, small villages. You can't find a neurologist in each and every village. So it is a responsibility of the primary healthcare provider, the medical officers who are MBBS, who are there in the small villages, tier 2, tier 3 towns, to diagnose and properly treat migraine. But both of these things are lacking. Recently, ICMR had made a algorithm for treating headaches and their other neurological disorders. So one of them was headache, and that algorithm was made in such a way that even the paraclinical staff can use it. So at least some of them can be managed by these paraclinical staff by giving them an appropriate medication and try to figure out the red flag signs where the patient with migraine is required to be referred to a higher center. And most importantly, the MBBS doctors who are graduating and who are performing duties at a village or tier 2, tier 3 level, they need to know to how to diagnose migraine. It's pretty simple. It's just a clinical diagnosis. No flashy things are required, and how to treat migraine. So again, even there, they at least should need to give proper medication both acutely and identify the patients who require a prophylactic medication. Even if they are not comfortable giving them, at least they can refer to them. So the currently the approach in, I would say, in tier 2, tier 3 and rural areas is pharmacy first. So they just go to a pharmacy, chemist, and they take whatever medicine the chemist provides. He doesn't know anything about migraine. So that should be shifted to a healthcare provider approach. So either an MBBS doctor or even a paraclinical can at least identify what the problem is, how severe the problem is, and can provide a proper medication or a referral. So I think this will go a long way, and obviously patient education. We have already discussed a lot about that. So this will probably help us in changing the reducing the healthcare gap, and obviously the government needs to know. So more advocacy needs to be done that migraine is not just a simple headache. It may not kill people, but it really destroys their quality of life.
Okay, so very well highlighted that you know it affects the quality of life. And on that, I would like to ask to Dr. Achal. So, because of today's workplace pressure, which is too much, specifically in the younger population, so how do you think this workplace pressure influencing the growing migraine burden in the younger population?
Yes, very relevant question these days, and specifically for migrainiers, I will say young age migrainiers. See, the current state of affairs is so that there is a kind of chronic state of, I will say, autonomic arousal in bigger cities like Delhi or Mumbai, or for that matter. Um, you can take other larger cities like even Jaipur. Uh, there are a lot of people. There is heightened sensory and olfactory kind of stimulus, eye stimulation because of various um, flashing lights and other things. So all these things give rise to sustained stress hormone elevation. So what happens with that? Uh, and with that, there will be some disrupted circadian rhythm as well. So what will happen? Sleep will be the pattern will be changed. There will be kind of like you are not sleeping because of various kinds of stimuli. There is so much sound you are unable to sleep, or there is a lot of light coming to your particular room. You are not able to sleep. This is a city problem, not a person's problem. In general, bigger cities problem. And on top of that, there is pollution. So there is kind of neuroinflammation, and with that again it is some kind of, it will give rise to CGRP thing, and this will give rise to headache in turn. So this is
Thank you.
two ways I told you. And
So,
then lifestyle, of course, these days people are unable to sleep because of several things, because their posting is like that, their job is like that, and some people in habit of seeing those reels produced by our um, Dr. Panga, so they are not able to sleep. And yeah, and another thing is workplace pressure. There are several jobs where you have lot of pressure. So again, all these things are such things which are basically these days seen in young men's life and young people's life. And All these things are probably giving rise to kind of headache which we are dealing in the patient these days. So all these things need to be acted upon. So on several things people can act by themselves, and of course government is working from its side, but again the effort is less. I expect more from the government, and I'm sure after some time or maybe a few years later we will be seeing some action from government on specifically on pollution. Thank you.
Thank you, sir. Thank you so much for highlighting that how work pressure is also adding a burden or one of the burden of migraine, and also highlighting on the pollution, the stress, and the urbanization. Moving to my next question, Dr. Vineet. So, as your reel is very well highlighted, that how it is
I will
helping
also
and
see that.
and also it is becoming one of watching a reel at night also becoming one of the reason of more episodes of migraine headache. So, if you could advocate for one transformative policy or healthcare initiative to improve migraine awareness and access to specialized care in India, what would it be?
See, आज जो सबसे important part है, most important thing is we have to increase awareness, and awareness is by talking to more and more people, and हमें we should not trust the systems as such. सिस्टम बनाया जाता है लोगों के लिए और लोग उसको फॉलो करें, एंड बहुत कॉमन एग्जांपल है कि जहाँ लिखा होता है कूड़ा मत डालो, वहाँ पे ही लोग कूड़ा डालते हैं। ठीक है, तो जो सिस्टम है वो इस तरीके का है कि हम सिस्टम पे बहुत ज़्यादा रिलाई नहीं कर सकते, बट इम्पॉर्टेंस ये है कि हम रिपीटेटिव हों। जो आज आपने इवेंट किया है दैट शुड बी रिपीटेटिव, एंड ये हमें एज ए न्यूरोलॉजिस्ट हम सबको पता है जो बात बार बार रिपीटेटिवली कही जाती है वो हमारे बिहेवियर को चेंज करती है। अगर जो बात कभी आई गई हो गई, आपने बोला एक बार, वो खत्म हो गया, तो उससे कुछ नहीं होने वाला है। इंडिया का प्रॉब्लम क्या है कि अगर लेडी को दर्द हो रहा है तो वो काम नहीं करना चाहती, अगर मेल को हो गया तो मर्द को तो दर्द होता ही नहीं। तो ये दोनों ही चीजों में हम लोग इतना लाइटली लेते हैं, हम लोग को लगता है नहीं हेडेक है, क्यों हेडेक है, छोटा सा हेडेक है, हमको क्यों वो करना है। सो वी हैव टू बी वेरी रिपीटेटिव, एज डॉक्टर अरविंद शर्मा सर बीइंग IASA secretary is doing a lot of things for stroke. Now we keep listening about stroke so much that eventually I'll tell you people will talk about stroke as much as they talk about heart attack. So the same should be migraine, and migraine is much more common. As Dr. Anshu sir said, it is bread and butter for all of us, mostly all of us. And if you see, almost 30 to 40% OPDs are of migraine, which itself tells you the burden of the disease. But what is more important is that we implement it at national level, probably get it added in national health mission, national health program in non-communicable disease, then keep talking repetitively about it, do such advocacies, bring in some media. आजकल लोगों को फ्लैशी चीज़ें बहुत पसंद हैं, इन्फ्लुएंसर्स बहुत पसंद हैं, तो वो इन्फ्लुएंसर्स को कुछ मीडिया के लोगों को लाके हम उसको ब्रांड एम्बेसडर बनाए हेडेक्स का, और जिससे कि हमको पता चले। जैसे मुझे खुद ही माइग्रेन है, एंड आई डिडंट नो कि मुझको माइग्रेन है टिल द टाइम आई वाज ट्रैवलिंग टू BLK. So I lived in Faridabad and I used to travel for 1.5 hour to BLK, and I realized that every evening I have headache. And then I realized that either I need to change my living place or I need to change my hospital and change the second one. So it is very important that we talk about it. The more we talk about it, the more repetitive we are, the more is the likelihood that the behavior of the people will change and they will know more about migraine and try to prevent it.
Thank you, sir. I think this is really impactful, and it would really able to help us get more awareness around migraine so that people will understand we can create this awareness and educate them together. Uh, before we go, I would just like to take a couple of more minutes of my experts here, because we have some good live questions from our audience. If I have that permission to take one or two, can I have the question on screen, please? So we have one question that how do menstruation, pregnancy, and menopause affect the migraine? Dr. Anshu, if you could help us
Yeah.
answer
So
this question.
yeah, I think it's a very good question. I think, and so first thing, I think most important thing is migraine is predominant, is more common in women than in men, and so there are a lot of hormonal factors which are really important in this. And especially there is a condition which is known as menstrual migraine, and we have certain patients who have especially increased frequency in and around the menstruation cycle. So I think this is because of the hormonal changes that occur. And even in pregnancy, we have a really tough time treating migraine because we can't give many drugs. So I think that is another very difficult area to really treat. So menstrual migraine is something which can be treated by this now certain triptans which can be used for menstrual migraine, and there's certain preventive strategies which can be helpful in these situations. So, and which has to be individualized according to the patient's profile, work profile. So I think we need to take cognizance of the fact, and we treat it. And so pregnancy and menstruation, they're two difficult times for women, because that is the time some of them have more of migraines.
Thank you, sir. Thank you so much for highlighting on this important aspect as well. We do have another question I would ask Dr. Arvind. So, after all this discussion, we had an expert panel and around 4 5 rounds of question. We are here with a question that can migraine be completely cured, or is it a lifelong condition? If you could answer this.
It's a very good question, and the previous questions are really good. I think you should have kept 45 minutes for the session and 15 minutes for the question. We are already overshoot our time, 1 hour 11
So,
minutes. So it's a good session. So Dr. Anshu said one thing: either you're born with a migraine, right, and it's partly being corrected by the lifestyle modification. So cure of the disease as a migraine, it is difficult to say, right, because it there are many factors. It's a very complex disease and it can happen to anyone, right? So you can treat it and you can prevent it to happen, rather than we can say we can cure the disease.
I think that this helps us understand, and I think this would really help our audience to understand the current scenario and how this can be cured. And yes, with better guidance, treatment, and everything, we do have a solution for this. So I would like to thank each of our esteemed panelists for sharing your valuable insights and helping us better understand migraine beyond myths. So today's discussion has reinforced one important message, that migraine is real neurological disorder, not simply a headache. A timely diagnosis, appropriate treatment, and patient awareness can make a tremendous difference in quality of life. I would like to thank everyone who joined us live today, and we hope that this discussion has empowered you with knowledge and encouraged you and to your family members to seek some expert medical advice whenever needed. Thank you so much to all our panelists for joining us and for sharing your expertise, insights with us, and helping us to educate our audience here. Thank you so much. It means a lot for us.
Thank you. Bye
Thank you.
bye.
Good
Thank
night.
you.
Thank you.
Good night.
Good
Thank
night.
you.
Thank you, sir.
Thank you all esteemed panelists.